Hello, and welcome to the next GRACE tutorial. Today we'll be talking about the GRADE Evidence to Decision, or ETD framework. My name is Suneel Upadhye. I'm an emergency physician and clinical epidemiologist working out of McMaster University in Hamilton, Ontario, on behalf of the SAEM GRACE working groups. Today, what we'll be covering is why evidence to decision make framework and understanding how to use this tool and the domains therein. We're going to reference back to examples from the GRACE 1 project that the group worked on in the spring of 2020. We'll make some quick comments about using the electronic GRADE Pro software available on the GRADE website and finish up with some writing of recommendations. So why do you need E2D? Because the clinical research is not enough in terms of the published literature. It lacks clinical context. You need stakeholder inputs, you need implementation considerations, and if available, resource utilization information. All of these various factors would have to be reconciled into making a clinical, meaningful, and actionable recommendations for the guideline writing groups. What the GRADE E2D framework offers is that systematic approach to integrating research findings into those contexts with those other considerations, and you end up with a thoughtful, well-informed, actionable recommendation at the end of your project. And this does require a variety of inputs from all the key panelists, stakeholders, when you get to the point where you're going to write your recommendation. You'll be familiar with this GRADE diagram from previous tutorials, and let's go through this a little bit. The previous tutorials on the evidence reviews will cover essentially how to do systematic reviews, starting with PICO questions, doing your literature searches, doing critical appraisals for all of that literature as you work your way across this top tier, deciding whether the quality of evidence for the PICO questions, the outcomes you care about, are high, moderate, low, or very low, and going through the exercises of how to upgrade the evidence or downgrade the evidence based on these categories before. And this has been covered in previous videos, so I'm not going to reiterate that here. However, once you've processed the evidence base, you then have to go through the activity of transforming that evidence with your panelists into recommendations. So this is what we're going to spend the balance of this tutorial on now. Recent article that discusses the iterative process of doing this from Rosenbaum et al. There's a nice graphic chart here of what that process looks like from top to bottom. It's not interactive, so this is just a PDF of that. So our groups transformed this into a working document using word processing software. And this is what the final template is going to look like this. The final result, of your assessment for your PICO question will look at these 12 domains. And we're going to go through these one by one. So the ETD categories in broad totality are 4. There are patient factors. There's the clinical evidence research evidence factors, which we alluded to before. There's resource factors. And finally, there's feasibility factors. And we'll go through these one by one. Just to note, these questions will be addressed actually out of order just because they fit into these categories more cleanly. So we'll take the categories on one by one. And then when you finally complete the summary table, you can allocate the judgments across the tool in the numeric order that's provided in the tool, but it doesn't really matter which way you do this. Like I said, we'll reference back to GRACE 1, and the one question out of the 8 that project dealt with is what we'll highlight here. So question number 1 from that guideline group was, in adult patients, that's the P, with recurrent low-risk chest pain, based on definitions in that project, is a single troponin, the intervention, compared to serial troponins, the comparison, needed for AC outcomes determination within 30 days. And that was the outcome of interest. And the details of all of this you can see here at the rest of the slide. So the question is, low-risk chest pain patients in the ED, single troponin versus serial troponins, does it have useful predictive value for ACS outcomes in 30 days? So question number 1 in patient factors deals with problem prioritization. So is this problem a priority to the patients? And this domain is rated on a Likert scale from yes to no, and there's an option that says varies. Detailed judgments in this section will also include, are the consequences of the problem serious, i.e. are they severe or important in terms of potential benefits or savings? Is the problem urgent? And is it a recognized priority based on political or policy decisions? Question number 6 deals with patient values and preferences. Is there important uncertainty about how much people value the main outcomes, and this is rated on a Likert scale from important uncertainty to no uncertainty. Some detailed questions here might ask, were patient values and preferences for each outcome ascertained? And if so, how? Did they use the grade tools and methodology? There's a 9-point Likert scale that you can look at prioritizing preferred outcomes. That's beyond the scope of this particular talk. Or does the patient values preferences information come from prior studies, published or not? And did they use validated PVP tools, yes or no? The importance of this has been recently highlighted by Zhang et al. There's an article looking at patient values and preferences to inform the importance of health outcomes, i.e. rank priorities, in guideline development using grade. Their upshot is there's no uniform means of establishing patient values and preferences, which makes sense because different projects and different questions necessarily involve different conversations and exploration of patient values and preferences. So you can't have a blanket one size fits all for this. So they recommended doing a lit review and seeing if that evidence pre-exists, which in emergency medicine is pretty rare based on my experience, or ask the patient, the caregivers, or any other public panelists who you've included as stakeholders on your panel. This is the importance of having these people on your panels. And then finally, at the end of your exercise and when you're writing your manuscript, you should report the patient and public stakeholder contributions using the GRIP2 checklist. And this is all available on the Equator Network. Another patient factor are the equity considerations. What would be the impact on health equity of whatever intervention your group is discussing? Again, this is rated on a Likert scale from reduced health inequity to improved health inequity, or it might vary. Detailed questions might include, is there an evidence base for addressing equity issues in your ER patient populations? Or has preliminary information already been gathered, and if so, how, on these equity considerations for the patients or the interventions that your group is discussing? Some more questions on equity. Are the recommendations equally accessible to all the relevant patients that you're going to be treating or intervening on with your question? Are there specific populations who are at risk of not being treated eligibly or equitably? And finally, are there specific barriers that would need to be overcome and facilitated in order to optimize the equity components of the recommendation your group is considering? More detailed questions here. Are there groups or settings that might be disadvantaged with regards to the intervention that you're looking at? There's 5 points on that Likert scale there. So different groups and settings might not retain the same benefits or suffer the same harm, so that has to be looked at. Are there plausible reasons for anticipating those differences in the relative effectiveness of your intervention for disadvantaged groups or settings? So that's something that has to be explored, ideally perhaps with your public and patient stakeholders with lived experiences. Are there different baseline conditions across the groups or settings that might affect the absolute effectiveness of your intervention in different groups and settings? Again, same discussion. And finally, are there important considerations that should be made when implementing the intervention so as to reduce inequities or at least make sure that they're not magnified? So all of these things should be considered when you're looking at the equity piece of the recommendation or the problem you're addressing in your project group. So in GRACE 1, question number 1, is the problem a priority? And this is the single troponin assessment versus serial troponin assessments in low-risk chest pain patients to make sure that there's no 30-day ACS adverse outcomes. So the judgment of this group was, yes, this is a priority. The research evidence, the comment written was, is there any epidemiological evidence on the numbers of patients arriving to the ED annually with low-risk chest pain and the subsequent troponin testing choices? So it seems like there wasn't a rich evidence base on this. And then other comments by this group included likely sources of significant practice variability in healthcare expenses, some ongoing research that was just published in July 2020. More research seems to be available for high sensitivity troponins versus conventional. Some of the people made specific comments about single versus serial. And then there was some comment about gender differences and machine differences and threshold problems. So all of these things were discussed by this group when they determined, yes, this problem is a priority. In question number 6, is there important uncertainty about how much people value the main outcomes? The judgment of the group was there was important uncertainty or variability, and this is problematic. There was no direct research evidence on patient values for low-risk chest pain presentations or the 30-day MACE outcomes, ACS outcomes. Somebody presented a paper pending evaluating the utility of second troponins and then integrating the heart score or other risk stratification tools in there. And there was some comment that Ericas had published some stuff from Mayo Clinic on chest pain choice research. So there is a body of evidence on that. Question number 10, what would be the impact on health equity? It was uncertain. According to this group, there was no evidence on health inequities in the ED or post-ED evaluation for low-risk chest pain. And then the extra comments were, will low-income underinsured patients with low-risk chest pain have access to healthcare after they leave the ED? There's inequities with follow-up access, but not in the ED workup phase, probably heavily influenced by local practice patterns and resources. So these are the comments that this group made when they answered those 3 questions and did their rankings. So looking at the evidence, this has been probably well covered in previous videos, so we won't have to spend much time on this. So the 4 questions are, what's the overall certainty of the evidence? How substantial are the desirable effects? How substantial are the undesirable effects? And then what's the balance between the desirable and the undesirable effects for whatever intervention your group is discussing? So the overall certainty of the evidence is rated on a Likert scale from very low to high. The ratings here can be transferred if you've done evidence reviews for each PICO question in GradePro, and you can just cut and paste or import the summary of evidence or summary of finding table. So that makes that easy. So there's not really any detailed judgments to be done here. How substantial are the desired anticipated effects? It's on a Likert scale from trivial to large. There's also an option for it varies or I don't know. One extra detailed question is, how substantial is the anticipated effect or difference for each main outcome for which there's a desirable effect? So you're going to have to go through this exercise of determining how robust the results are for each outcome that has a good outcome, a good benefit for your intervention of choice. Same question for the undesirable effects. How substantial are the undesirable effects? The same rating tool, trivial to large, varies, I don't know. And then the detailed question is, how substantial is the anticipated effect or difference for each main outcome for undesirable effects? And then finally, you finish with a balancing of the 2. So balance between desirable and undesirable effects for the intervention of choice, rated on a Likert scale that says favors the comparison to favors the intervention. It varies, or I don't know. More details, obviously, on the balancing of effects are discussed here. Reading down, is there important uncertainty about or the variability in how much people value the main outcomes? And that would have been covered probably in the first batch of questions we talked about in green, the patient values and preferences. Questions 1, 2, and 3 that we looked at here right now covered the certainty, the desirable, the undesirable effects. And then finally, there might be some consideration about other factors in the valuation of outcomes. So how much less people value outcomes that are in the future, so later on in life, compared to right now. So those are time discount factors, and there might be a literature on this, or you might need some expertise on your panel to help try to navigate this. Some questions around attitudes of patients towards undesirable effects, so if they're risk averse, and attitudes towards desirable effects, or how risk seeking they are with regards to the intervention that your group is considering. So in GRACE 1, the overall certainty of the evidence was low. The comments here were that there was no direct evidence identified, no indirect evidence on recurrent chest pain, and the indirect evidence on low-risk chest pain with 30-day MACE was 9 studies with quite a low event rate, 0.5%. And other ideas that were shared in the box were articles don't take into account the time since symptom onset, very low prevalence of outcomes in these studies anyway, so it's probably hard to know how to chip into that further. Very early onset, i.e. 3 hours or less since symptom onset, you can't use a single troponin to rule it out. So those are the comments made by that group for that question. How substantial are the desirable anticipated effects? The group decided that they were probably small. Theoretical benefits to decrease time in ED and decrease hospital admissions, but the beneficial outcomes were not actually addressed in any of the included studies. Some commentary by the group, clinical experiences, time savings is judged as real. Patients would probably like it if they were poked less painful. And John, who was one of the patients actually on that group, did indicate that patients would appreciate if they were in the ER for less amount of time, as long as the physician explained to them that it was safe to do a single test, or if there was a need for a second test, that they would rationalize that in a shared decision-making conversation. Question 4, how substantial are undesirable effects? Same conversation, probably small. The harms from a missed AMI or 30-day MACE with serial troponins may be more useful than a single, but the pooled event rate was 3.4 out of 1,000 patients. So the considerations were that AMI and MACE rates heavily weighted was towards the high sensitivity troponins, but the conventional troponin data didn't necessarily disagree. I wasn't part of this group, so I can't speak to that with great confidence. And finally, the balance between them all. The determination was that it probably favors the intervention compared to the comparison. Again, no direct evidence on this or indirect evidence on harms or benefits in that regard. Previously discussed about upgrading the criteria. The benefits probably outweigh the potential harms. And there was a comment from Dr. Gottlieb. You could potentially use the boarding literature to hypothesize about harms and see how it applies to this question. Moving on to the next category of questions is resource requirements. So question number 7 is, how large are the resource requirements and costs? A 7-point Likert scale from large cost to large savings, or it varies, or I don't know. You can get costing information perhaps from economics databases if they apply to the emergency department. So HEED is one international database. CADITH is a Canadian one that talks to economic evaluations, some of which is relevant to the emergency medicine spectrum of practice. There might be published formal economic evaluations, studies, or health technology assessments. My experience with this in the emerged literature the last 20 years is this is very rarely done, and really important that this get done in the future. Or for this for your project, you might need to do some de novo resource utilization and costing information to be able to start filling out these boxes. Detailed questions to consider in this for resource requirements is, how large is the difference on each item for resources for which fewer resources are required, and then how large is the difference on each item for which more resources are required. So does it use up more resources or does it use less resources, whatever intervention you're looking at? What's the cost of the intervention alone? That may be just at the ED level. It may not have to do with downstream costs, what have you. And economic evaluations in general require a lens from the perspective of who's the payer, an individual, an insurance company, government plan, a hospital, whatever. So you might need to know the burden of illness numbers for the population of interest, and then you can start to calculate per person costs and then aggregate costs for all of those groups that we discussed, and how are these viewpoints being judged and rated. And this is all kind of higher, more detailed economic information that having an economist or somebody who's familiar with this methodology on your guideline panel is a good idea. Question number 8 deals with resource certainty. So what's the certainty of evidence of resource costs, requirements, what have you? So it's a 5-point Likert scale, very low to high, or there's no included studies. Some more details is, again, we've talked about where to find costing resources from databases if it's available, CADITH, HEED, or whatever. And you can cut and paste the links, actually. You don't have to write the whole article. Just put the website or the URL link or the PMID number into your table, and then the readers can look at it later if they want to go through your appendices or supplemental materials, if that's what you've included. Have all the important outcomes of resource use that may differ between options been considered? How certain is the cost of the items for resources that are being compared? And is there important variability of the cost of items and resource that differ between the options being considered? So these are all things to analyze if this information is available in the first place. Question number 9 is the cost effectiveness comparisons. So what's the cost effectiveness of the comparison of the intervention or the comparison, and in favor of which direction? So it's a 7-point Likert scale, favors the comparison versus favors the intervention. It varies, or I don't know. Extra questions might be, do the comparisons compare cost effectiveness, cost benefits, or cost utility? And these are formal economic evaluation methodologies that are pretty much completely lacking, to my knowledge, in emergency medicine. But this is what economists do well, and they measure different things and they mean different things to the audiences. So it does behoove having an understanding of such if it's available. And then finally, were these measures actually determined in ED patient populations, or are they being extrapolated or adapted from other information sources and imputed on what ED populations might prefer? More detailed questions here. Is the cost effectiveness ratio, so the CER, sensitive to one-way sensitivity analysis or sensitive to multivariable sensitivity analysis? This is generally way above the head of most practicing clinicians. And this is where having health economists, ideally emergency medicine health economists, would be helpful on your panel groups, like I said. Is the economic evaluation on which the cost effectiveness estimate based is reliable? So there are literature review critical appraisal checklists. One is literally called the checklist, CHEC, for critically appraising and scoring economic evaluations in the literature, just like Consort is for randomized trials and Prisma or other tools, START and what have you for systematic reviews. There are economic evaluations, critical appraisal tools, and if you have economic evaluations, then you can use this tool and answer these questions. Finally, is the economic evaluation on which the cost effectiveness estimate based applicable to the settings of interest. So does this apply to where you're going to work? And that's important adaptation and knowledge translation to the workplace that every literature review question eventually has to address. So from Grace 1, this was easy. There was nothing. How large are the resource requirements and costs for the single troponin versus serial troponin literature assessment? The group didn't know because there was no cost analysis of troponin testing strategies that they could find at all. Question number 8, the certainty of the evidence. Well, that's easy. There was no included study, so there's no certainty. There were some comments that there was a manuscript that showed some cost consideration on serial troponin. There's a PMID reference that suggests there might be no difference in cost in whatever setting that article looked at. And Henry Ford Hospital, there was 2 hospitals with 150 patients being looked at from an economics perspective. That was offered by one of the group members. And the cost of effectiveness of the intervention in favor of one or the other, again, no included studies, so there was no way for this group to make a judgment call whether it favors A or B. So the final domains for consideration in this framework are acceptability. So feasibility and acceptability, so implementation. Is the option acceptable to key stakeholders? It's a 6-point Likert scale from no to yes, and there's varies. Some key questions are the key stakeholders that would not accept the distribution of benefits, harms, and costs? So there might be some stakeholders on your group, patients or whomever, that don't find that these recommendations or this evidence is acceptable for those parameters. Are there key stakeholders that would not accept the costs or undesirable effects in the short term, but in the future they might? Or they wouldn't accept that distribution of harms and costs like we discussed above? Are there key stakeholders that would not agree with the values attached to desirable or undesirable effects? And this is getting back to those green things around patient value preferences, and different groups may not share the same values and preferences. So that has to be explored every time you apply this in a real clinical work setting. Does the intervention option adversely affect people's autonomy? 5-point scale there. That would have to be discussed, probably under the revisiting the equity concerns here. And then finally, are there key stakeholders that would disapprove of the intervention morally for other reasons other than autonomy? So non-maleficence, beneficence, justice. And again, your patient stakeholders will give you their lived experiences to talk about these things to a certain degree. Feasible to implement, 6-point Likert scale, no to yes, and it varies. Detailed questions, is the intervention sustainable? So if you start it, can you keep it going? Because that's of little value if it's a good intervention, but you can't sustain it. Are there important barriers to implement that would limit the feasibility of the implementation that need to be overcome, and then create facilitation strategies to optimize sustainability? So 2 questions to look at there. In the Grace 1 group, is the option acceptable to key stakeholders of single troponin testing versus serial troponin testing? The group said probably yes, although there was no research evidence to back that up. John, the patient advocate, did provide some input at some point. There was a cardiologist involved in that group. They looked at some cardiology guidelines that suggested that the recommendations in their world might be different than what we would do in our world, specifically around the utility of high sensitivity troponins and times of onset. So that was addressed by this group. And then from a feasibility point of view, they said probably single troponin testing is implementable easily compared to serial. Again, no evidence to really back up those claims or statements. Some comments that the choice of troponin assay was out of the hospital's control anyway, or out of the emerged group's control anyway. Single troponin based on assay may be inadequate, and the majority of the research seemed to revolve around high sensitivity troponin. So when you have done the detailed work in all of those domains, again, you're going to come back and revisit this chart and summarize it. So this was the blank template I showed you at the beginning of this video. Now for the Grace 1 group, that question I showed you, here's how their answers summarized. So problem priority, didn't know. So overall certainty of evidence, very low. Undesirable effects, don't know. Undesirable effects, maybe some small information on that. Balance of effects, don't know. Patient values and preferences, don't know. Resources required, don't know. Certainty of evidence required, resources, no included studies. Cost effectiveness, no included studies. Equity considerations, don't know. Acceptability, probably yes. Feasibility, probably yes. And this is just my own color coding, just for a quick snapshot visual of good, bad, and neutral. You can look at this however you want in any other visual fashion that's appealing to your group. Finally, you have to actually frame your recommendation. So we're getting to the point of going through all of those domains, and now you have to write a recommendation. So you're going to be able to write strong recommendations, which from a policy perspective could be operationalized into performance indicators for audit, feedback, quality improvement. From the patient perspective, the statement of a strong recommendation would be that most patients in this situation, the clinical scenario that you've laid out, would want the recommended course of action, and only a few may not. And from a clinical perspective, you would recommend the course of action or the intervention your group is examining. Now, for a weak or a conditional recommendation, there still has to be some debate and involvement of stakeholders. So this is where giving the patients more say and shared decision making. They always have the final say, but more information to make their own judgments is more important. Recommendations shouldn't be used for performance metrics and audit and feedback and quality improvement. From a patient perspective, a majority of the patients may want the recommended action, but many would not. So again, more conversation needs to be had and more options have to be laid out for the patients between you and the clinician. And from a clinician perspective, you're going to have more information at your beck and call, at your fingertips. So when patients start making their own judgments based on values and preferences, you can help inform that process as they get there. And then finally, when it comes to writing the recommendation, it's either going to be a strong recommendation or conditional or weak. And it's either for the intervention of interest, against it, or neutral. So if you use the electronic version, you might see this blank grid at the end. So what's the recommendation? You put your question in the pink band at the top, your starting question. Your overall judgment of the entire group of 12, you would put across these 5 domains and you pick one box. The type of recommendation is going to be a strong recommendation against, a weak recommendation or suggestion against, a weak suggestion or conditional recommendation for the intervention, or a strong recommendation for the intervention, whatever it is your group is looking at. So suggest, recommend, for, and against. The justification, you can write whatever you want in this box. Are there specific subgroups that need to be considered differentially? So you may want to write some caveats and comments here that would eventually end up in your manuscript as to how to differentially apply these recommendations. Again, from an operational perspective, emerge docs love pathways and protocols and algorithms that they can adopt or adapt into the workplace right away. The preferred attributes of clinical practice guidelines for emergency physicians has been measured and published by Abel Sood in 2011. So emerge docs want algorithms and pathways in their documents, so make sure you provide that if you can, and performance indicators for measurement and for audit and feedback, give it to them. And then give them all the recommendations right at the beginning. Emerge docs, short attention span, they want their answer right away. So give it all at the beginning. Ideally, you should have some medical education types in your clinical practice guideline group, and they should be able to plot out a knowledge translation dissemination strategy to get these out into real world practice and use. Monitoring evaluation criteria, we've talked about defining key performance indicators, and then perhaps even giving them tools to implement for performance measurement and a measurement schedule for PDSA cycles if you're doing quality improvement. And like every article, you're going to finish off with where are the gaps in the research, where are the gaps in those domains that you covered above in this talk, and using the tool in that dozen, and then what are the next steps for research to fill those gaps. So in GRACE 1, the recommendation was, in adult patients with recurrent low-risk chest pain, we suggest a single negative troponin, doesn't specify high sensitivity or conventional, below the measurable threshold of your hospital, presumably, to rule out ACS within 30 days. And this is a conditional recommendation for that intervention. Balance of consequences, the group decided desirable consequences probably outweigh undesirable consequences in the settings that this will apply to. The type of recommendation was a conditional suggestion for the option. And the rest of the chart, they didn't really address or fill this out. So close to the end here, using GradePro. So the GradePro platform, web-based, will give you a free account for you and your group if you would like to use it, depending on the depth and breadth of your project. And it'll help you manage your ETD components online. So your groups can meet at different times and keep populating different elements of the domains and the tables until you get through them all. You answer all your Likert responses per question, as we've discussed. All your supporting questions, detailed questions can also be answered. Put all that information in, and then it'll spit out a summary at the end. So here's what question 1 might look like. This is some project on oseltamivir for influenza. This is just for training purposes. So question number 1, you can see the judgment is here on the 4-point Likert scale, yes, no. The research evidence, you might want to just put in some of the lit review that you've done or the intro to your paper. That would be a good spot to put this in. At the end of it all, you'll get the summary of judgments table, a little more clean than the color-coded one we use in the Word document, but whatever, it all sort of aligns similarly. There are the dozen categories, and then you see what you see here in terms of the output, and then you can use that to inform writing your recommendation. So wrapping it up, I know this was a long whirlwind. Translating your research evidence into guideline recommendations has to embrace other areas and domains, including patient values and preferences, resource issues, and then finally implementation issues. It's always critical to maintain a patient-oriented focus on all of these discussions and evaluations. If you have the information for patient values and preferences, equity, resource issues with regards to patient values and preferences, that's great. Other than that, just get patients or stakeholders on your panel and let them help you with their lived experiences to evaluate all of these things and eventually get to your recommendation, and then report their participation using the GRIP 2 checklist as the reporting guidelines for GRIP 2 that I previously alluded to. Information for resource considerations might be previously accessible or published, or you might have to just make those determinations during your own project. It just depends on the topic you've chosen. The recommendations at the end should be acceptable to all the end consumers and ideally feasible to implement. You don't want to make it impossible to make a recommendation for something that people just can't do. And then finally, make a decisive statement. It's either strong or weak and conditional, and for or against your intervention. Binary decisions, intuitively acceptable and obvious for your target audience. So we'll stop there. I hope this video is of some value to you. It's a lot of work and a lot of detail, but it's worth it at the end, and it's explicit for audiences and for journal editors and authors how you got to your recommendation and how you can justify it. And all of these tools can be included in supplementary materials when you do your article submission after your manuscript is completed, if that's something the target journal will allow for. Again, thank you very much, and good luck on your project.